So, oral histology and genetics. These are the tissues we're going to be looking at. Let's take a closer look at some of them. Just to remind you, this is a tooth. I felt someone should point it out at some point in time. We're going to look at the structure of the teeth and all that fun stuff in a few days. But just to remind you, that is the gingiva that you're dealing with, the mucogingival junction, alveolar. What I want you to do is please take a look at the lips here. Here is your labial mucosa. I have that here. And clearly, here is the vermilion zone at the interface of the teeth, of the skin. So we're going to take a look at that kind of tissue in a moment or two. So the components of the gingiva for me are the oral epithelium, the sulcular epithelium, junctional epithelium, and the gingival connective tissue that we want to take a look at here. So we're going to try to break down the different zones, and you can see that we're transitioning from one type of epithelium to another here. So what we have here is the marginal epithelium. We're going to take a look at this. I'm very interested here. We spend some more time on the junctional epithelium. Here, of course, is your attached epithelium, and here is your sulcular epithelium. This is really the weakness for me in the whole tooth structure. Here's your enamel space. Here's your crest, as you will know, and the unique type of epithelium we have on this side versus that side, and the change in junctional epithelium. So we're going to take a look at that, and here are your alveolar crests, as you well know. So it is, I have to put it down, this is what you're doing for a living, so it's an interesting part of the body for the most part. It is from the thinnest epithelium in the body and the softest epithelium in the body to the thickest type of tissue and the hardest tissue that we have for the most part. It is uninterrupted for the most part. It's continuous with the skin of the lip, right by the vermilion zone of the lip. It goes all the way down to the pharyngeal area and clearly to the soft palate. All of this is a continuous strip. Again, it's a barrier. It's very much the way we speak about saliva. It has sensation. It's got heat. It's cold. It is neurologically one of the richest, most sensitive areas, huge parts of the brain. When you take a look at the homunculus, are associated with the lips. We have some life-saving reflexes besides it, such as the swallowing reflex, which is a very important reflex, and the gag reflex, also a very important. Both of these are survival reflexes, as is the vomit reflex, also very, very important. And it's for absorption. We'll speak about that. We take a look at the epithelium. It's secretory in many ways because of the saliva. In humans, we don't really release much heat with it, but it is the primary way when dogs pant. It is the primary way by which dogs cool off. That's the only mechanism. They have all that fur and hair, and they can't release heat that way, and they don't sweat. So the only way they can do it is by panting. Very important in dogs. It's for excretion. Very, very important too, because your saliva has all kinds of metabolites or waste products for various parts of the body. And of course, aesthetically, very, very important. So your oral mucosa, it's really the anterior part of the GI tract, has to be very, very moist again. And it's really the mucous membrane. And for us, that's what I can call it. So again, everything that we've gone over in terms of functionality, very, very key. So it's organized a number of different ways. We have masticatory, lining, and specialized mucosa. Masticatory mucosa is about a quarter of all the oral tissue. The predominant one is the lining mucosa, and that is your gingiva, your interdental, that's your hard palate. Masticatory mucosa is predominantly keratinized with different types of layers of keratinization. So it's your primary thing. Lining mucosa really is the floor of the mouth, the buccal cavity, the ventral area of the tongue. That's the underneath of the tongue, as you know. All right? It is usually non-keratinized. It is rich in collagen. It also is rich in elastic tissue, which makes it very soft and pliable, which it has to be. So you can do that and whatever, it doesn't rip apart. Then you have specialized, and that is the dorsum of the tongue. So here we can see different types of epithelium, from the small intestine, which is columnar, to the cheeks, which is really non-stratified squamous, non-keratinized. While you're asking me now, remind me later, this comes up 3 times an hour. Then you have your hard palate, and that's your masticatory, and that's kind of a little bit different. The hard palate and masticatory is really right over here, underneath bone, right above bone, and we're going to speak about this, which is kind of important in many ways. So this area here, I want to show you this. This area here, this from here all the way down here, kind of interesting, is what we call the lamina propria. That's the underlying connective tissue. That is usually areola, loose, irregular, collagenous connective tissue. And over the bone, you have periosteum. You see that? That's that denser connective tissue. That is outside bone. Please look at this. This is very, very important that we begin to understand that, and I'll explain that in a moment. Just to show you, that is the mouth, am I right? So again, just to repeat: hard palate, gingiva, lining of soft palate, ventral tongue, floor of the mouth, cheeks and lips, and again, parts of the tongue here. So again, here in text form, I've just isolated down here, but what I've added on over here is the lining mucosa is non-keratinized stratified squamous epithelium. All right? It is pliable. It is stretchable. Very, very important. Masticatory mucosa is very, very different. It has to be a resilient, a strong type of tissue. And we begin to come to 2 new terms. We speak about it in terms of keratinized or parakeratinized. I speak it in terms of ortho and parakeratinized, and I'll go through that with you in a moment. And then again, the specialized has the lingual papillae, the 4 different types of lingual papillae, and we're going to speak about the keratinized in a moment here. So the layers that we have in the oral epithelium in the lining mucosa is the bottom layer, the basal layer. We have the spinosum, and a superficial layer, which is your stratified squamous non-keratinized epithelium. Here is your lining mucosa, so let's take a look at this. We see high amount of elastic fibers, and what we're going to take a look here, see that limit here? This, from here to here, is the mucosa. That encounters the epithelium and the lamina propria. Further down the GI tract, we have over here a muscularis mucosa, which makes the mucosa. But here, we tend to have your non-keratinized stratified squamous epithelium and your lamina propria. Here, are they really in skin? They're called dermal papillae. In the teeth, they're called reed pegs. Then here we have a submucosa. Submucosa is not present in all portions of the mouth or the oral cavity. We're going to learn where they are. Now this is kind of important. When you take a look at the soft palate, the floor of the mouth, the lips, and the cheek, when you do an injection, you inject in this area here. Okay, that's kind of interesting because when you do the injection, the submucosa can absorb the bolus that you inject. All right, so that when you inject into the arm or the gluteus medius, it has enough fat, it has enough mucosa, so if you put your bolus in, it can stretch and respond to that stretch. It's not too painful. And I'll mention this again here, whoops. The iPad is not as responsive as I would like. Time to buy a new one. So what we want to do is understand that it is relatively thick. When we take a look, I'm going to go back over here. In this, see here, I'm just going to mention this to you. This is the periosteum. There is no submucosa here, correct? Because there's no submucosa, we call this mucoperiosteum. The mucoperiosteum is very important because that's how we attach the mucosa to the underlying bone. One thing I'd like to point out to you, when you inject into this area, right? Think about your hard palate. When you inject into the hard palate, do you have much room for stretch in that tissue? And because you don't have much room for stretch, when you put in a small amount, you stretch it, but you have nerves in the lamina propria. So an injection, a bolus in that area is more painful because the space that you're injecting in is much smaller, less stretchable and pliable than other parts of the body. And that would explain why it would be a little bit more painful to go into this area. All right? We have the basement membrane. Here, a small submucosa. So we depend on the type of tissue. The layers that we have depend where it is. Is it alveolar? Is it labial? Is it lingual? Buccal? Very differences. So here is your oral tissue. It is the epithelium, the LPs, lamina propria, and the submucosa. So what we have here, if we take a look at the oral mucosa, it is the basal layer, the intermediate layer, and the superficial layer. Okay? Here are the reed pegs. You see that? You know what the reed pegs are, right? The reed pegs are to do what? To hold on to the tissue. Not all reed pegs are identical in all tissues. As you get older, this is a good question, obviously, we spoke about before, the reed pegs get shorter, right, and fewer in number. That's what we look like, okay? So again, this shows you the submucosa, shows you that it's highly vascular, highly neurotic, not neurotic, very neurological. Shouldn't have said neurotic, that may be driving you crazy. So we have a number of different cells. We have 5 types of cells. I know I have 4 over here, but I'll explain that to you. Why? We have the epithelial cells, which are the keratinocytes for us, with the different levels. It's about in skin color. They're held together by desmosomes or macular adherens. We had the Langerhans cells, which are your antigen-presenting cells. Okay, their Langerhans cells are extremely close to the basement membrane with type 4 collagen, just as a reminder. And you have Grandstein cells. Grandstein cells are like Langerhans cells, okay, but they are found in the oral cavity. You have Merkel cells, which are fine receptor cells, and melanocytes, which do not store melanin. They just produce it and send it into the keratinocytes where they're stored in melanosomes. So we have in the oral epithelium, we have a maturing population and a progenitor population. Progenitor populations undergo cell division to produce new cells. Those are our stem cells. And then, of course, okay, we have the rapidly growing cells. Turnover time, I think I want to explain this to you. The typical turnover time from basal layer to superior level of skin could be between 50 and 75 days. In the GI tract, I think I told you it lasts about 17 days, but really 4 to 17, 14 days in that range. Your gingiva, when you go from basal level production to removal, is about between 41, 57 days. Your cheek cells only last 25 days. And again, your junctional epithelium, which is really hidden and gets a great deal of abuse, really only lasts less than a week. So there's a high amount of turnover in that junctional epithelium. You spend a lot of your time in junctional epithelium. So we have the non-keratinized, parakeratinized, or orthokeratinized epithelium. So here's your gingiva. Here's the alveolar mucosa, which is stratified squamous non-keratinized epithelium. Okay. So here is the keratinized oral membrane. So we have a number of things here. We want to take a look at the top layer, which is very important for us. So here are your Merkel cells, your melanocytes, your spinosum layer. Okay, now, so what we have here is the orthokeratinized, the parakeratinized, the non-keratinized stratified squamous epithelium. In the orthokeratinized, that's more or less what I've taught to you. The superior cells are secreted in what we call squams. They're flat, they're long, they're dead. Okay? So there are no, it is really dead tissue lining the layer of epithelium here, granular layer. In parakeratinized, a little bit different. We think it's an intermediate form type of epithelium, but the top cells are different. The top cells, the nuclei are visible. They're pycnotic nuclei. Pycnotic nuclei are, when you take a look at a cell, they're very dense and very dark and very round. They're dead. So again, this is the bottom layer, the basal layer. It's attached to the basement membrane. Again, it really will undergo the division. For the most part, it is essentially active mitotically, and here we have the stem cells. Here's the polyhedral cells, the spinosum cells. We can see the nuclei. We see attachments called the desmosomes. The granulosum, we're making lots of granules, and we begin to see the nuclei die. On the basal part, by the way, we have, just remember, we have basement membranes, and of course we have hemidesmosomes. The spinosum is really, they shrink from each other only in histological preparation for the most part, and again, desmosomes are important. You'll also see here some of the Langerhans cells. They're active in protein synthesis. In the upper layer, in the oral cavity, we're going to see cells that have granules called Odland bodies. And they are lysosomes for the most part. They come from the Golgi apparatus, and they release a particle that's a permeability barrier that protects the upper layer of the oral canal, of the oral mucosa. Again, I'm just repeating that. The keratinized epithelium, you see no nuclei, you see no organelles, and this is really keratinized or orthokeratinized. All right, lots of regular tissues. Okay. Now, when you see parakeratinized epithelium, they're really on the hard palate. It is considered normal. You can see parakeratinized epithelium in regions of the gingiva. You can see parakeratinized epithelium on the skin. If you see parakeratinized epithelium on the skin, it is pathological. And an example of parakeratinized epithelium in the skin, I think I mentioned it in a few slides from now, example would be psoriasis. So normal in the oral cavity. So the whole thing is really based on location. I think I have it right there, sorry. So parakeratinized again, cells are dead, but they have the nucleus. Orthokeratinized is really the stratified squamous that you guys are somewhat familiar with. That's non-keratinized. I just like how that looks. All right, so in non-keratinized epithelium, they're all alive, no keratin, they have nuclei, and that's really everything with the lining of the oral cavity. So here you see the tooth, you can see the alveolar, the non-keratinized, the difference or the separation you see in non-keratinized and keratinized epithelium. All right. The difference, all right. Okay, and here is the example that I showed you here that here is what you can see, this mucoperiosteum for the most part. Again, in the intestine, you'll see a very thick submucosa, and you'll see something called the M&Ms, separating the lamina propria from the submucosa. In the gingiva and the hard palate, it is the oral mucosa that attaches to the periosteum. So again, this is really an important thing. And that could be a good question. I should remember all these questions. I'm reminding you. The lamina propria essentially has two layers, a papillary layer, which is by the reed pegs, and a reticular layer, which is parallel, whoops, writing on the wrong computer, I should get another one, which essentially is really, fibers are very thick and run parallel. Again, the lamina propria is highly vascularized. We find fibroblasts, a variety of macrophages that are floating here. We find the mast cells. We have neutrophils, which are the PMNs. Lymphocytes, plasma cells, really anything we find that we speak in any time of connective tissue. On the ventral part of the cell of the tongue, that's a little bit different because the epithelium is relatively thin, all right, and it's directly attached to the muscles. And muscles and the tongue is probably one of the most muscular organs that I can think of because you're able to use it in mastication, you use it in speaking, and it has, per size of the organ, it probably is one of the most muscular. There's one other that's maybe more muscular than that, but it's not on a test. So here is the cheek. Again, all kinds of mixed salivary glands. Now, on the floor of the mouth. Here is the epithelium on the floor of the mouth. Here is the submucosa. Very, very important. So we attach, on the floor of the mouth, the tissue underneath. What's very important about this is, sorry, I'm going here. The floor of the mouth has the thinnest epithelium in the body. Okay? Why is that important? Because when you give a patient a drug, like if they're having angina and you're giving them a nitrate, you give the drug sublingually. Why sublingually? One, because it's the thinnest, it absorbs relatively rapidly. And two, remember when I was teaching the smooth ER, I said it's involved in drug detoxification? I also mentioned that when you take a drug, it goes into the stomach, it goes to the liver, we modify the drug. I said something that it's called the first pass effect. We can eliminate half the drug within a few minutes. When you give a drug sublingually, all right, it directly goes the distance here. It's absorbed by the veins and goes directly to the heart relatively quickly, giving you an effect within 15 to 30 seconds. So we have two things. One, the histology, and two, the anatomy that's very, very important. Here's the submucosa. Again, it varies in thickness from the buccal, remember, right, to masticatory. The difference is whether the mucosa is available or not, or the size. Again, your handout goes to this. I'll take care of this for you. Again, submucosa is not present, parts of the gingiva, not present in hard tissue. So, wow, fast. So your oral gingiva, again, resistant sulcular epithelium, is either parakeratinized or non-keratinized. It is not orthokeratinized. Sulcular epithelium is para with dead nuclei, or, now remember, parakeratinized is an intermediate form. I think that's a good way of looking at it. It's intermediate between non-keratinized and orthokeratinized. That's why it has dead nuclei. Junctional epithelium, when we're now coming around to the junctional epithelium, it is non-keratinized stratified squamous. So we're going from the sulcular epithelium, which is non-keratinized, to para, junctional epithelium with stratified squamous, non-keratinized. Okay, now, who cares? You care. So there is your masticatory mucosa. Okay. The gingiva, sulcular, and junctional epithelium is continuous. We said that. Gingival epithelium is masticatory. Junctional epithelium attaches the gingiva to the tooth surface. You can see the ligaments. The junctional epithelium is circular. It goes around this entire tissue. Okay? And it's attached to the tooth, the enamel, and underlying connective tissue. I just want to show you lining, get that there. Okay. Okay. Okay, the palpula. Okay, here. Specialized. Okay, just as a reminder. Now, again, what's important about this is, and we'll really take a look at this in a minute or two as well, the coloration of the area depends on a number of things. It depends on whether, it depends on how close the capillaries are to the surface. Take a look at your lips. How are they red? Are they light colored? Are they darker? Never look at lip color without lipstick? Ever think about why they're different colors? You have different colors of lips. One, how close the surface is. So here, parts of this, part of your lip is translucent, so you can see underneath. But also, color represents how close the capillaries are to the surface of the lips. The deeper they are away, the lighter the lip color. The richer the lip color, the closer they are. When you undergo vasodilation, okay, blood vessels get wider, you have increased blood flow, the color becomes deeper, more red. When you vasoconstrict, the color becomes lighter. If on your lips you occlude blood circulation to them, what color do your lips become? What? When you're shivering and you're retaining body heat, what color do they become? They become bluish. Why? There's no blood circulation going to that tissue. If you have a patient who's exposed to carbon monoxide poisoning, the lips turn blue because there's no oxy or deoxyhemoglobin there. So the thickness of the tissue, the lower the degree of keratinization, the richer the color, got that. Colors affected by melanin production, got that. And the state of blood vessels over here. So clinically, that color is important. So if you take a look at inflamed oral tissue, remember, when you have inflammation, what are the four characteristic signs of the cardinal sign of inflammation is this redness. Take a look at the inflammation. What does that tell you? that tells you increased circulation, vasodilation, leakiness, swellingness of tissue, pain, all occurs right here, all related to what we've just really discussed for you. So the oral tissue is different than skin. It's moist. The color is very important. There are no hair follicles in the oral cavity. I don't think. There are except no sweat glands and no sebaceous glands except in Fordyce disease, when you can see those small little collections, yellowish, whatever color they are. Those are really a disease of sebaceous glands, am I right? Yep. And they are really in the upper lip, the buccal mucosa, and the alveolar mucosa. All right? Again, you'll have salivary glands in the oral mucosa. You don't have that in skin. And again, the texture. All right? Oral mucosa is silkier than skin for the most part, except the tongue. And the oral tissues vary in firmness depending on its function for the most part. So there's skin, there's the cheek, whatever have you. Now there are a picture of Fordyce spots. Some could be a normal variation. Some could be much more problematical. I think I've isolated them here for you. Okay. Okay, just going to do that. So here are some salivary glands. Here you see the sebaceous glands going to the surface. Everyone is just so happy. So the lips are keratinized, stratified squamous epithelium, right over here. The oral mucosa, moist, non-keratinized. It's got the lamina propria, submucosa, and you'll see muscle, the orbicularis oris, in the oral, especially in this area. The vermilion zone right here is thin, it's easy to cut and easy to bleed. All right? Keratinized epithelium, okay, with lots of sebaceous glands right over here. Why the redness in the vermilion zone? It's because we're transitioning to a very thin epithelium. And in the lips, in that area, you have this chemical called the elidin. And remember I said this tissue is transparent. That's because of this one chemical in it, which changes as we go further down. And again, blood vessels are near the surface. So some patients, my vasculature is very, very thin over here, so that if I get an irritation, I will bleed very readily. And it's really hard to stop. All right? Some people, well, don't punch anybody. Your soft palate is kind of interesting. Your soft palate is non-keratinized. It is pinker, which means it is more vascularized and closer to the surface. So here, the difference between the hard palate and the soft palate is this. It's got the presence, because it's softer, of a submucosa. I know I'm repeating myself, but you'll learn it. The hard palate, really, is only lamina propria that fuses with the periosteum, and it's called mucoperiosteum. So you understand the pain. Okay? So because it has a submucosa, there's a lot of reasons. See, here's the cheek, which is similar to the lips and the soft palate. Okay? And by the way, lots of fat cells in your cheeks, which is why people plump them up. I'm not saying anything here. All right? All right, we did that. Just a reminder, this is what that is. Again, just as a reminder, because I know you study, because I believe is you want to make what we call tertiary memory, short-term memory, and the best way to do this is repetition. So I'm forcing you, if you read the PowerPoints, to get repetition. So when you take the exam, you'll be listening to me in your head. Okay? And this is how I like to teach. Lots of repetition to make sure that you learn. So this is your study session, right? You're my study buddies. I did this for all my kids. I sat through all their biochemistry, histology, and anatomy courses and pharm courses. I'm tired. Okay. Now, I'm not adopting you, and two, I am not paying your tuition. I've been paying. So is that a student loan or is that? It's either asking me for a new car warranty. Now they're asking me to pay if I want to pay off my student loan, or it's asking me, I don't know, 1,000 to 3,000 questions. No. Okay. We're doing very well here. Oh, stop it. You want to go home on the weekend, on a hot day? Relax. I can hear the moaning, please, please. All right. Okay, in healthy mouth, you know attached gingiva causes stippling. Here's your interdental teeth, your interdental papillae, as you know. You have the valley there, as it's called the interdental caul. I don't have to tell you that because you're all pros. So now what we want to take a look here is really take a look as we're going into the junctional epithelium. We're going to take a look at that in a minute. So in the gingival sulcus, that's the space between the tooth surface and the free gingiva. It is lined with sulcular epithelium. All right? So it goes until the junctional margin. So the junctional epithelium, which is kind of interesting, is stratified squamous non-keratinized epithelium. All right? Holds onto the tooth surface. What makes junctional epithelium unique and different from sulcular epithelium, it has two basement membranes. Two basement membranes, because it's located in covering two surfaces. It has an inner and an outer basal lamina. It is the seal of the gingival epithelium and in the tooth, where you're going in there with your tools, right? It goes into the enamel of the tooth. So what our issue is, as you well know, is the deepening of the sulcus. And that's a sign, obviously, as you, I'm sure, heard 3 zillion times. Again, in sulcular epithelium, there are no reed pegs. Sulcular epithelium is continuous, as we've said that before. Sulcular epithelium, as I mentioned before, which is what we're seeing, can be parakeratinized or non-keratinized, and this. What determines whether it's non-keratinized or parakeratinized, and that is the degree of infection the patient has. It is representative of the infiltration of the connective tissue of the white blood cells, the neutrophils, because what we'll have here is a high concentration of neutrophils, high concentration of lymphocytes. Teaching you path. Okay, now, the dentinogingival junction and junctional epithelium. So the dentinogingival junction is where the oral mucosa meets the tooth, and we're going to speak about this right now. It's important because, remember I said everything is continuous, so in the area of junctional epithelium here, in this area, this is the place where you're prone to infection. It is the weak link really in the oral cavity. So what happens is if you don't brush teeth, the bacteria attach to the surface of the tooth. Bacteria release toxins that can even cause heart attacks, because heart attacks, some of them are due to inflammation. There's a nice relationship. I shouldn't say nice, but you know what I mean. So what we're doing is you produce toxins, you cause an irritation, and because of that, what you're doing is you're getting infiltration of the tissues. You have your swelling, you have your mast cells, you have macrophages, you release histamines, you release bradykinin. It's really interesting. If and because of that, You can have obviously, the solstice gets longer. So this periodontal pocket is now undergoing histological change. All right? That change is kind of problematical because, again, we're losing whatever parakeratinization we have, and it's non-keratinized epithelium, and the points of attachment will even weaken. All right? Where does it come from? It comes from something called the reduced enamel epithelium, which I will teach you for your final, unless you wanted me to do that today. But then I have to do 3 weeks of lecture in one shot. Okay, so junctional epithelium is our seal. It forms during tooth eruption, which I will show you right now. It has the 2 lamina, okay? The other difference here, which is why you want to take care of this, is that the junctions that hold the tissue together are reduced in number. So you don't have the same attachment between the cells. You don't have an occludens junction. You don't have the zonular junctions. You have more of the spot junctions. And because of the spot junctions, and you can even reduce in number, the tissue is leaky. So you can have bacteria and toxins enter into the tissue because you lose epithelial cell integrity. And because of that this tissue typically has inflammatory cells. Again, if it's not cleaned out, you have these problems. And we have a rather interesting cell turnover, and you can see what happens here. In junctional epithelium, the cell turnover is 5 to 6 days. What does that indicate? That indicates, very simply, that this tissue is under constant stress. Bacterial cells cross the epithelium and start your immune process. You decrease keratinization, and you have leakage of exudate into the space, into the clavicular space. When you have an infection, the rate of flow and odoriferous bacteria increase. And normal flow is good, but when it increases and have a change in color or bacteria, it is now called an inflammatory exudate. And that's what you're probing at. And again, you know all about this. I am not going to go through the fibers for you on this lecture, okay? This should be a review of your free gingiva, keratinized, not stippled. Attached gingiva is keratinized and stippled or stippled, whatever you want. And again, can be attached by junctional epithelium. Okay. Hard palate is masticatory. We spoke about palatine glands. So here, how the gingiva and junctional epithelium develop. When you have the tooth, this is an erupting tooth. The outside of the erupting tooth has a membrane called the reduced enamel epithelium. When the tooth begins to erupt, this epithelium meets the oral epithelium. Okay? So there is a fusion of the reduced epithelium, reduced enamel epithelium, and the oral mucosa. The tooth then pressures upward and compresses the tissue. So where the white spots emerge, where erupting tissue is, that's an area where there is no blood flow because we're compressing the capillaries. If we compress the capillaries, we damage the tissues, we release lysosome, we damage the tissues, and we erupt. But when we erupt, this area, this reduced enamel epithelium and the oral epithelium are fused together. And that is how we form junctional epithelium. So it's the eruption of the tooth that does this. So we have in the hard palate, we have your fatty area, and posterior, really the back part of the soft palate here, is your glandular area. Okay? Now, this is really where we are coming to a happy end. This is from your textbook, which I know some of you haven't bought. Okay? So this chart is important, and it's part of a handout that I've given you. So let's go through this. What we're looking at is whether or not the thickness of the tissue, whether or not we have the lining, whether or not what kind of epithelium we have, and whether or not we have a submucosa. So please read this over. Whoops, it's going a little quick here. Oh, we got the tongue to do here. So sorry. Okay, so go through the areas, the floor of the mouth, very thin epithelium. It has short papillae. It does have some fibrous connective tissue and minor glands. The lining, the soft palate, has thin epithelium. It's got lamina propria, and it has some salivary glands. The floor of the mouth, the alveolar mucosa, is thin, non-keratinized epithelium with short papillae, short reed pegs, with essentially it does have a submucosa. Labial and buccal mucosa is relatively thick. It has the reed pegs, okay? And again, the mucosa, there is a submucosa that's attached to underlying muscle, very important. The lips, the vermilion zone, is orthokeratinized stratified squamous epithelium, narrow papillae, and the mucosa is attached to the muscle. The lips, the intermediate zone, which is along here, okay, it's thicker, parakeratinized epithelium. It does not really have much of a submucosa. Masticatory mucosa, like the gingiva, thick, ortho and parakeratinized, or orthokeratinized, and really has no distinct submucosa. Hard palate is orthokeratinized, sometimes parakeratinized. It has papillae holding the tissue together, and it's really dealing with the mucoperiosteum. Then we come into the tongue. Should be done in a few minutes. For taste and sensation, it's got your papillae. The dorsal surface has the specialized mucosa. The body of the tongue is the anterior 2/3. The root of the tongue is the posterior 2/3. The posterior of the tongue also carries the lingual tonsils. Just as a reminder, in the back of your oral cavity, you have the lingual, you have the palatine, and you have the pharyngeal tonsils. They form a ring around the pharynx. Do you know what that ring is called? It's called Waldeier's ring. Don't look at me because it's question 31. I'm not going to make you memorize tonsils, but you got to know Waldeier's ring. So all the tonsils in back of the mouth really protect, and that's called Waldeier's ring. It's even in your A&P book. So here you see the lingual tonsils. Here you see the palatine tonsils. and that we have a ring all over here, and that's Waldeier's ring. We have the circumvallate papillae that form the V. We have the folate papillae, filiform papillae, which are angled backwards, so you can, and fungiform papillae at the tip. So here is the lateral areas of the tongue where you can have folate papillae. Here's the dorsum of the tongue. You have minor salivary glands in the musculature right around there. In the ventral surface of the tongue, okay, you have stratified squamous epithelium. It's also good for absorption, but remember, you really want the bottom of the ventral surface of the tongue and the floor of the oral cavity. That's really where we do the major absorption for sublingual, under the tongue absorption. So you have filiform papillae, which make the majority and non-taste portion of the tongue. It is pointy, as you can see, and it's pointy to force the food backwards and to break the food up so when you compress it against the hard palate. That's have you ever seen the hairy tongue before? Do you know one disease that does produce hairy tongues? I'll give you a hint. It's 3 words. First 2 words are hairy tongue. What's the third? It's a leukemia. This could be carried, so hairy tongue leukemia, as a side result of leukemia, you begin to see a different number of conditions. Fungiform papillae are fungus-like, as you know, and they're usually found between the filiform papillae. They're much more numerous at the tip of the tongue. Okay? There are some taste buds, not a lot, but there are some taste buds. Okay? Fungiform, there are fewer, as I said, some taste buds. Folate papillae, they are very important. They have lots of papillae, 5 to 10 papillae. The papillae, the folate papillae decrease as you get older. Okay? Again, not really prominent in humans, but there are some. Circumvallate papillae are humongozoid papillae. Here you'll have von Ebner's glands here, and they could have up to 100 different taste buds, and they are serous, obviously. Just like I just love that picture. Okay. The glands, taste buds. What you see here is really, here you have an opening called the taste pore. Here are the neurological cells, the chemical receptors, and here are sustentacular or support cells. Very clear here. Okay. So taste buds. I'm going to skip this one because we have too many different types. But taste buds are really neuroepithelial cells. Every taste bud has about 100 taste cells for the most part. Lots of very important in terms of transmembrane receptors. The tongue isn't the only part that has taste. It is the soft palate has taste buds, the epiglottis has taste buds, larynx has taste buds, and your oropharynx has taste buds. So we say that again, we do this, I don't like it, but I mention it, and I'll tell you why I don't like it. So you have these sensations, sweet, salty, bitter, umami. We have sweet and salt, we say, are in the anterior part of the tongue. The sour, we tell you, are in the lateral part of the tongue. And bitter is toward the posterior part of the tongue. And actually, bitter as well is really on the soft palate. So we teach you this starting in elementary school. And we give kids taste tests because we totally want to frustrate children and say, taste this, you can taste it. You ever do that in elementary school? You taste different chemicals and put it in parts of it, you do that. And you always have frustrated kids. It drives me crazy because they never can taste it in the right part of the mouth, so they think they're abnormal. So I will tell you recently, they've discovered that the taste buds are more spread out, okay? But we continue the experiment. You want to know how recently it was? In the 1930s. So we've been teaching it to you. Why do we teach it to you? Because they make quick experiments and we try to localize it, but they're much more spread out. It's been disproven even from before I was born. So I mention it to you because that's what the books have, but it's not true. Okay. I put that in there. So as you get older, reed pegs decrease, slow mitosis, you lose elastin, so your tissues do not respond as well. You have disorganization of the collagen. And then you get to go home.